Hi, I'm Heloisa Soares. I am a GI, medical oncologist and neuroendocrine tumor expert at the Huntsman Cancer Institute in the University of Utah. Immunocompromised is someone that has a weakened immune system, right? Meaning that this person is not able to fight infectious as someone that has a normal immune system. And then things that can compromise the immune system can be someone that has a chronic illness, such as cancer or HIV or AIDS. Um, Someone can also be immunocompromised because of medications that they are taking, and that will then we'll use the term immunosuppressed. There's other conditions that can also make someone be immunocompromised, such as some genetic disorders that the patient might have been born with. That's a very good question, and we're still learning a lot in terms of what can happen, but there are some evidence from small studies, and particularly one study from China, that patients that have cancer might have worse outcomes if they were to develop an infection with COVID-19. So the term oral cancer therapies is very broad, right? They can mean several different things. So it's really important to talk to your doctor to understand what type of oral drug you are on, such as if this is a hormone related that probably wouldn't cause a lot of immunosuppression, or if this is a TKI that can potentially has the impact on your immune system. Also, there are some chemotherapies that we can use that are oral. So it's very important to touch bases with your physician and understand the possible side effects of your treatment, because just oral therapies is a very general class of medications. That's also a very good question. And honestly, we struggle with that to some extent, depending of the cancer that they have and depending of the indication that they have. But I can tell you that for most of the cancers, particularly in solid tumors, we are still moving forward with treatment, particularly in the metastatic setting, meaning, patients that have the disease spread to other organs. There are a few circumstances that perhaps someone has a very slow-grown tumor that there might be a rationale to delay treatment. And I treat a lot of neuroendocrine tumors, so when I think about that, I can give you the example of someone that has a very low-grade, slow-growing, low burden of disease neuroendocrine tumor. These patients might be able to wait until this pandemic improves before they start treatment. But that's a very case-by-case decision, so I will really consider discussing that with their physicians. But in general, for most of the cases, I think it might be very challenging to delay treatment, particularly for someone that has a more aggressive tumor. And I can give you the example, someone that has a pancreatic adenocarcinoma that is metastatic, right? These patients cannot wait to receive treatment if they decided that they wanted to invest on anti-cancer treatment. So I think this can be also personalized, and normally when we have recommendations about doing scans on patients and labs, typically we have a range. They should be done between 3 to 6 months, and each physician discuss with their patient if they're okay, I'll bring you back in 3 months, I'll bring you back in 6 months. But now, under the conditions that we are, it's very reasonable to actually use the extend period. Let's say it's a recommendation to have a scan between 3 to 6 months, you do it in 6 months to push back in a safe manner. So I would recommend to everybody that has potentially a scan schedule, and is on surveillance, meaning no active cancer, to call their physician's office and discuss if it could be pushed back and postponed in a safely manner. So we're all doing that. My nurse is calling all my patients to discuss delaying some scans when it's safe and appropriate.